Renu.
Declan, well done.
Thank you very much.
EAU Madrid, you've just been up on stage discussant at the game-changing plenary.
I know. Well, if you can't read out in the game-changing plenary, as you did 2 years ago with lutectomy, second best prize is the person who gets to do the discussion. So yeah, it was a huge honour to be
You were much more favourable than my esteemed discussant.
Who was your discussant?
The lovely Alberto Briganti.
Oh, Briganti. Yeah.
That was very nice. He was very gracious.
That's because he likes you. Yeah.
But rightly so, because what an amazing paper.
Yeah, so look, we're posting this podcast in the middle of the EAU Annual Meeting in Madrid. And one of the great privileges we have is knowing some of the practice-changing papers that are being presented. And these are the biggest sessions at the EAU, aren't they? Practice-changing plenary. And that's where we reserve the very best work. And so what's just happened today is that a much anticipated trial called the Translate trial from the UK has just been presented for the first time and has also been co-published in Lancet Oncology. So it's a big deal in urology to have that sort of, impact.
Absolutely. I mean, we do see some great research at these practice-changing plenaries, but it's not often that you also get a co-publication in a major journal like Lancet Oncology.
And how hard is it? This is a surgical trial.
For a surgical randomized trial, exactly. Incredible. Yeah. So huge congratulations to the authors, and we had to have a chat with them, didn't we?
Exactly. So, hot off the plenary stage, we are inviting the lead author who presented this trial, Richard Bryant from the University of Oxford, to talk to us about the trial, and senior author and friend of the podcast, Alastair, also of the University of Oxford. So, gentlemen, well, congratulations, first of all, on this great moment for you, all your collaborators, all your patients, in having the Translate trial read out at the EAU and having this big publication. Richard, we'll go to you first. Congratulations.
Thank you, Declan, and thank you for having us on this GU cast. This is a real privilege and real pleasure to do this with you, and thank you for being the discussant earlier today. And we're delighted to share the results with you and hopefully inform patients and the urological community of what we've found and what this means.
Fantastic. And Alastair, welcome to you as well, a friend of the podcast, and co-author on this amazing paper. Congratulations. It's a massive piece of work.
Thanks, Renu. Declan. It's a real treat to be back on the podcast.
Sure is. And he's an ex-Melburnian fellow. He spent a year with us at Peter Mac a few years ago again. So you're always very proud. You claim the credit for it, of course, when they go on to great success. Like, we taught him everything he knows, etc. But
we should get into the meat of this trial, because this is the age-old debate, right? Transrectal versus transperineal biopsy. And in Australia, we feel like we've kind of put this debate to rest, but it's not the same in many parts of the world.
And of course, there've been some randomized trials of transrectal versus transperineal biopsy, but this one is very different for very many reasons. It's why there's going to be a lot of conversation about it. It's why we're so thrilled to get a bit of a deeper dive into it today. It was a very short presentation today. That's the way it is in plenary, and the paper is out there, but people won't have digested it.
It's also the reason why it's in Lancet Oncology as well.
That's right. Exactly right. But on the podcast, we get a chance to dive deeper. So we're going to ask Richard to tell us a bit about this trial in a moment. But first, Alastair's going to kind of set the background. And Alastair, as I sort of just said there, we've had transrectal versus transperineal before, but this is sort of, I think, the one that, as I said in the discussion, really settles the argument. And the previous trials have focused on, well, what about sepsis, etc. If you put the needle through the skin rather than through the poo, as we say, clearly it must be safer. And I suppose that's kind of presumed to some extent, although some of the trials haven't really established it. This trial set out on a much more ambitious and meaningful endpoint. So tell us a little bit about the background to Translate, why you set it up, how you came to this study question, and then Richard will take us through some of the data he presented today.
So, as you said, Declan, we're certainly not the first people to speak into this debate. Quite a bit of coverage over the past year, a collection of exciting randomized trials came out, Pro-PC, Prevent, Perfect, and if it's okay, I'll come back to them in a moment. But perhaps if I could just set the context for how we set up this trial, I think that's interesting, and maybe just spend a few moments on that. So we set Translate up back in 2019, 2020, when many of us will remember there was a real kind of groundswell of movement towards LATP. Well-known urologists like Hash Ahmed at Imperial, or UCL then Imperial, Roberto Miano in Rome, Matt Alloway in the US, Rick Popert, my new colleague, I've recently moved to Guy's Hospital, my new colleague there, saying that prostate biopsy didn't have to be done transrectally and could be done transperineally. Indeed, during my fellowship with you guys, I think there was a bit of pride, might I say that, in the fact that no transrectal biopsies were performed. Everything was done transperineal, although actually they were all done under anaesthetic at that point in 2016, weren't they? So yeah, real enthusiasm towards TP biopsy, particularly perhaps because of the possibility to perform it under local. And there was an RSM, a Royal Society of Medicine ski trip in early 2019. Richard and I weren't there, but John Renard, one of our wonderful senior colleagues in Oxford, was. And as some who've been on that meeting will know, there's sort of, yes, presentations, but lots of chance for discussion as well. And apparently sort of the discussion came up, what is the best thing to do? Good question to ask. Why isn't there a really high quality trial? Shouldn't the trial be done? And I think Richard might correct me, but I think John emailed us from the meeting to say, why don't we do this in Oxford? I guess because we'd just written up with Francisco Lopez a case, sort of multi-center case series of over 1,000 LATPs published in BJUI. And I'm slightly shamefaced to say it, but I wrote an email in response using phrases like "this ship has sailed," "the horse has bolted," and
the train has left the station.
Yeah,
the train has left the station.
It's too hard.
And Richard he's nodding, but he'll confirm that he's hung on to this email to sort of rub my nose in it once in a while since then. Yeah, that was the sort of context into which we were speaking. Now, you asked me for a bit more of a sort of summary of what we found in the last year from these trials. So shall I move on to that?
Well, maybe we'll dive a bit into the trial design and eligibility and all that. So kind of, I suppose, having established that transrectal versus transperineal, John and co thought it deserves to be studied. But, maybe one of you can answer. But what was the pivot towards asking about the primary endpoint you got to? Yeah, because this is very interesting. Yeah. So, Richard, maybe we'll throw to you for that. And then from that, I suppose, we'll flow how you set this trial up, what you did, what's unique about it. And what did you report today?
Yeah,
sorry, if I may, just also summarise the trials that have already been published, because obviously there are some really cool trials that have been published over the last year. I'll do that whenever you think it's appropriate. So,
well, yeah. So with regards to it's great when we look back actually at how this came about. And Alastair and I remember we had a weekend of lots of discussion, and we thought of a name for the trial, and we really thought after some consideration, we really should try and do this and lead it from Oxford. We've got the trials unit here, we've got good links with colleagues in the UK, and we thought we really could do it. And as Alastair alluded to, all of that drive towards LATP was all based around infection. And of course, that's very, very important. But we also were of the view that, a man doesn't have a prostate biopsy to avoid an infection. He has a prostate biopsy to either find, or hopefully not find, clinically significant prostate cancer. And so that was the main reason that we thought, well, look, why is the man having the biopsy in the first place? It really is all around the cancer that you find, or don't find, hopefully. And of course, infection is important, but we knew if we could power this study, and we'll come on to that in a moment, well enough, we could try and answer both questions. But in contrast to the other trials that Alastair will talk about in a moment, which have mostly featured around infection, we really thought that cancer detection should be the primary outcome.
Why did you think that? What made you think that it was going to be inferior? Was it back to the old promise data? Why did you think TRUS was under diagnosing some of these significant cancers in the MRI era?
Well, I think it wasn't so much that we thought that they may be underdiagnosing. We in Oxford, as in many other places, we're still doing TRUS biopsy just before the COVID pandemic. And we really wanted to robustly evaluate one against the other in an RCT, and really do it head to head. And as we'll drill down into in a moment, set it up so that we try and avoid bias, we have equipoise, and we genuinely do an RCT. And at the time, we didn't know the other trials that Alastair will talk about in a moment were even happening. When we applied for funding for this, we didn't know the exact landscape of what else was, potentially starting in other countries, which Alastair will talk about now. So we just set out to do our trial.
And I think, those of us who have taken up transperineal biopsies, our justification is not just the infection, but also we've always said, it's better sampling of those anterior tumours.
We can target better.
We can target better. I mean, we've always said this, but we never really had the evidence to show it. So, yeah, very interested to see how you set up the trial. I mean, an amazing amount of patients that you recruited into the trial for such a short period of investigation.
Yeah. So Richard, let's do that. Let's go into the trial design, how you set it up, and the endpoint, and then Alastair can put it in context maybe of the other trials out there. But yeah.
And also we should just say to our listeners, LATP, those who haven't read the paper, is local anaesthetic transperineal biopsies.
Correct, because here in Australia we tend to do them under general anaesthetic, and that's been one of the points of resistance, I suppose, is saying, oh, come on, we can't be bringing these patients to the OR.
That's right.
The Americans will certainly tell us that. So so this was kind of going to go straight to, no. It's all local anaesthetic. Everyone can walk home. So yeah, back to you, Richard.
Yeah. So when we set this up, and Alastair and I, we reached out to people that we know around the UK to see who could be interested to join us, on this venture. And we have very good connections with the urological community, and we tried to incorporate sites that were both now doing LATP, but also hadn't completely abandoned TRUS biopsy. Because again, as I mentioned earlier, we needed equipoise, we needed to be able to deliver either type of biopsy. Of course, that then meant that some centres, particularly those in London and some of the big metropolitan areas who'd already completely transitioned to LATP, they couldn't join us. Of course, this was also being set up during COVID, actually. I think we got funding just as COVID started. So we had to deliver the trial and recruit this huge number of patients. And it is a testament, actually, I think, to everyone who worked on the trial and indeed the patients that we had, as we'll drill down into, very, very high acceptance rates of the type of biopsy that men were allocated to. I think 97% of men had the biopsy that they were allocated. And that also speaks to the quality of the recruiting, actually, that happened. It's across 3 of the home nations of the UK, which I'm really proud about. England, Scotland, and Wales were involved with this. So, and again, we set out to do a really pragmatic trial. A real world evaluation of these 2 types of biopsies, one against the other. And then in terms of numbers, so we knew that in order to identify what we thought would be perhaps a 10% uplift in the detection rate of clinically significant prostate cancer, and I use that term cautiously because that's evolving, of course. We knew we would need just over 1,000 patients to detect with sufficient power this hypothesized 10% uplift from TRUS to LATP. It turned out that actually, because we had a small number of withdrawals or perhaps crossover patients who didn't accept allocation, we actually kept going a little bit longer till we ended up with, I think, 1,126 patients. And that was all approved by the trial steering committee. So we managed to recruit those patients in under 2 years. I think it was 21 months of recruitment.
Amazing.
During COVID.
During COVID.
So you've finally included over 1,100 patients. None of them had had a biopsy before. They've all had an MRI before, which is a very incredible part of this. So they were having targeted and systematic biopsies all during COVID. It's kind of amazing. Just hats off to running a trial like that. Yeah.
Thank you very much. Yeah, they had. So as you know, in the UK, standard of care now for quite a few years has been for patients to have a pre-biopsy MRI, and we mandated that for eligibility in the trial. And again, we set up a very pragmatic inclusion and exclusion set of criteria to really make this a trial that will inform patients, to the maximum ability that we could do it.
Yeah. So we should go over the results. And so these were all patients who had MRI, and it was all cognitive targeting of lesions, correct?
That's correct. Yeah. So all patients had an MRI. They were all biopsy naive. They all underwent cognitive biopsy. They all had one of the really important factors, and Alastair was a huge help with this, was to really set up both the LATP and the TRUS to have equivalence of the number of biopsy cores taken. So we had very detailed protocol around the number of target cores to take per lesion, but also the number of systematic cores to take. Because one concern we had when we were setting this up is that the LATP may take, twice the number of systematic cores, for example, and that sampling bias then would affect the results. So we were very, very careful to make sure that the protocol was well written to avoid that cause for bias. And you're right. So all patients then had LATP or TRUS cognitive targeted. I think 90% of the patients had at least one significant lesion. We're still evaluating a lot of the correlation between the lesion and the content of the biopsy, and that will come hopefully in future publications. But then, and then we followed the patients up very carefully. So the patient-reported outcomes around tolerability, infection, health-related quality of life, cost effectiveness, that's all built in.
Which is it's so important, isn't it, Alastair, that part of the deal with this is you're very accurately measuring the patient experience of transrectal versus local anesthetic TP biopsy. And that just creates an incredibly rich tapestry of data that we can look to as we see how can we improve all these methods, or how do we counsel patients about these methods.
That's right.
That's worth a whole other podcast on its own, because the supplemental tables in this are just incredible. But yeah, so your thoughts on that before we get back to the primary endpoint and the key secondary endpoints, Alastair?
Yeah, so we'd love if we have a bit of time just to talk about that and our sort of health economic analysis, because we haven't mentioned that yet, but we recognized that the scope of what we had the potential to discover would be broadened by including colleagues in Oxford who had the skills in those areas to both through the sort of historical protect learning of the importance of patient-reported outcomes, which everyone knows now, but wasn't the case sometime a little while ago, was it? And then also the health economic analysis, is this cost effective? And so we have incorporated those, pretty much front and center in the study, and at least the patient-reported outcomes are in the paper that we've published. Might I spend just a brief moment, and because I mentioned at the start that we're not the first to do randomized trials in this space. I think I can do this reasonably rapidly. Is that okay?
Do, because the audience are waiting for this primary endpoint to come out. We've strung them out long enough, but they're all waiting in great anticipation. Yes. Yeah, shoot, Alastair.
But see, one always hesitates to summarize other people's excellent work quickly, but I think I might be able to do so. So, EAU, AUA 2024, 3 trials presented, the 3 Ps, so Pro-PC, Prevent, and Perfect. Pro-PC from Albany, New York, single center trial, Beda Mian, the leader of that. And their primary endpoint was infection. They found no difference, although, important to emphasize that was with no antibiotics in LATP and targeted prophylaxis for TRUS, which was interesting. Prevent, Cornell, also New York, Jim Hugh, the lead investigator, 3 centers, again, primary endpoint infection, again, no difference, but this time very close. And interestingly, they added a few more cases and then published it again in JAMA Oncology, and the p-value dropped below 0.05. Let's move on. So Perfect, Paris and Toulouse French trial led by Guillaume Poussard, 3 centers again. This time, their primary endpoint was detection, but they found no difference. In fact, TP biopsy seemed to do slightly worse if you looked at the posterior lesions. And so by the middle of last summer, those were the 3 trials that were in everyone's minds. And Richard and I were getting a little bit edgy because we didn't know the results from our trial. And we realized that we were now not speaking into a neutral space, but actually perhaps the bar had started to move slightly. Not that people who were previously convinced about LATP had completely changed their minds, but I suspect some listeners were beginning to aware that there was a potential for a few red faces, and certainly quite a bit of debate in the prostate diagnostics space. There you go.
Excellent. Very nice summary.
All right, Richard, over to you.
Okay. Yeah, so Alastair and I, as Alastair alluded to, we were trying to hold our nerve really last summer when these other trials were publishing, not knowing our own results. So to come on to the results, the big headline, I guess, is with our primary outcome of detection of clinically significant prostate cancer. which we defined as grade group 2 and above. So we did find a statistically significant uplift in the rate of detection of grade group 2 and higher disease in the LATP arm versus the TRUS arm. We saw an uplift from 54, just over 54% to just over 60%. And that obviously was testament, I think, to, again, as I alluded to before, the control we had, the quality between the two types of biopsy, that we had very similar numbers of cores taken from both the targeted and the systematic regions of the prostate. And so we were delighted to be able to say earlier today that we do see that statistically significant uplift in grade group 2 disease. So it may be worth just spending a moment on that, and then perhaps we'll tell you more about the secondary outcomes.
Yeah. Wow.
What do you think?
Yeah, I mean, it's significant difference, all right.
It sure is, and that's what it was powered for.
Yeah.
Questions people will have within it, as you alluded to, is how clinically important that is, because nowadays many of these are quite favourable intermediate risks that we might just keep an eye on. But nonetheless, that wasn't the purpose of the trials, to see have they a better outcome. It was a detection thing.
Yeah.
But you did comment that in a subgroup. Sorry, go ahead, Richard.
So I was just going to say that of course, things have evolved even during the conduct of this trial. So the PROTECT 15-year data hadn't been published when we set up this trial, and so we did build in some other exploratory analyses, which we can touch on later, where we have an alternative definition of clinically significant disease, where we set it at grade group 3 and above.
Yeah. Well, that's what I was about to ask you. Yeah, because there was no difference or no real difference when you only looked at grade group 3. Now, I know it was a subgroup analysis, not powered for, etc. But what's your take on that?
Yeah, so, we're still doing, as I mentioned before, sub-analyses of lesion location and so we can't really talk about that yet because that work's still ongoing. But we have noticed for sure that in the last, I guess, 4 years, maybe 5 years, a lot more of our grade group 2 patients are now going on to surveillance. Of course, we don't know how long they'll be on surveillance. They may well need some treatment, within a small number of years of being on surveillance. But, you have to draw your line in the sand somewhere as to what you think is significant disease. And back 4 or 5 years ago, we set it at grade group 2 and above, which in fact the other trials that had detection in their secondary endpoints, they also set that bar at grade group 2 and above. So I think the fact that we were powered for cancer detection is the big difference between our trial and the others.
I would also defend that endpoint as well, Renu, by saying that it's not like if you diagnose grade group 2 cancer, that's massive overdiagnosis and they should never be treated, because even if many of them go on surveillance, most of us will say it's still important to diagnose the grade group 2 cancers they can have better characterization using imaging and better analysis of subtypes, cribriform, etc., maybe PET scans that we tend to use. So I don't think we'd ever be able to say, look, the reason this endpoint is not of relevance today is because of that we actually surveyed them. Grade group 2, heterogeneous thing, and it's still, I think, very important to make that diagnosis, even if at the end of the day, some of them will be on surveillance.
I completely agree, Declan. I mean, this, like you said, this is a detection trial. You're purely seeing which modality is better to detect cancer. And I agree. I mean, adequate mapping of cancer is important in active surveillance, especially when we're pushing active surveillance to grade group 2 disease. I think it becomes all the more important.
So I don't think that's any sort of diminution of how important that primary endpoint is.
Richard, did it surprise you that TRUS biopsies did as well as it did?
It didn't surprise me, actually. I think it might have, forgive me for saying it might have surprised Alastair slightly, but I wasn't overly surprised. And we did see that TRUS is actually, dare I say it, it's actually, a good type of biopsy. It did detect this, higher volumes of disease, or higher proportion of disease than we thought it would, actually. I think that speaks to the MRI era. We'd done previous work, which we published. I published a series from Oxford in the JUROL a few years before Translate, but that was when we used to sample everybody, regardless of the MRI finding. And so we actually found TRUS was a good biopsy. LATP, though, is better at detecting clinically, or what we define as clinically significant disease. The infection, coming on to the secondary outcome, again, we were surprised that the infection rates, again, were relatively low for TRUS. We weren't powered to detect a significant difference between LATP and TRUS. But I think I'm right in saying this is now the largest trial of biopsy-naive patients to have been done. we do see slightly higher numbers for LATP than TRUS. I don't think we were surprised by that. But it didn't, and you'd have to do a really large trial, probably, many, many thousands of patients to reach statistical significance, I think, for infection. But TRUS is not as bad for infection as perhaps was being made out in the urological community, I suspect. Do you want to say a few words about that, Alastair, if I may? Because this was something that you were very interested in, right?
Yeah, thanks. I mean, look, I wonder if, so quick step back. I think we were fortunate that we had this LATP series that I mentioned a moment earlier and Richard's TRUS series to base our power calculation on for the primary outcome, and also to base our sort of thinking on for the secondary outcomes. But they were in a different era, and particularly the TRUS data. So I genuinely think we have perhaps overstated the infection rates with TRUS biopsy. And if you think that a lot of those TRUS series have come from large cosmopolitan centers where perhaps ciprofloxacin resistance is higher, throw that into the mix as well. And again, another reason why maybe we've overstated the degree of infection in TRUS biopsy. So when you think about it, perhaps not as surprising, and again, maybe revealing a little bit of the preconceived biases which some of us who were enthusiasts for LATP had adopted.
And they weren't, unlike the PREVENT trial and PRO-PC, the TRUS biopsies didn't have any sort of targeted prophylaxis, did they, or augmented? They weren't swabbing the rectums beforehand.
No, we used the standard of care approach at each of the 10 centers. So they all used their rectal swabbing that they would use in terms of cleaning. So most of them would have used povidone iodine. All patients who had TRUS clearly had prophylactic antibiotics according to local practice at each site, which was important because, again, I go back to we really wanted to do a pragmatic real-world trial. Importantly, and again, this was something that Alastair, you were extremely keen on and had, great vision back at the start. We had in our protocol to have the LATPs done without prophylactic antibiotics. Yeah. And in fact, I think very close to 90% of the patients that were randomized to receive LATP did not have antibiotics. The relatively small percentage that did were based on perhaps either a protocol deviation or an on-the-day decision by the clinician doing the biopsy. But the vast majority of LATPs were antibiotic-free, and that's really important, as you know, for antibiotic stewardship.
Absolutely.
And preventing
you can't overstate that. I think it was just this week, somebody from the WHO again was standing up saying antibiotics, the end of antibiotics era will come. We won't have them forever. Use them wisely, etc. Yeah. And surely that would be an important consideration here, is the fact that you were going with almost no antibiotics up against, as you say, local protocol, which can be like 3 days or 4 days of quinolones and precious antibiotics. And again, I think we can't make enough song and dance about that, to be honest.
Richard kindly credited me with that, but actually just on the sort of team concept here and trial setup, actually it was Hide Yamamoto from Maidstone who was actually at the point of setting up his own trial with infection as the primary outcome, not detection, and was absolutely sort of emphasizing the no antibiotics whatsoever for LATP. And when we had a conversation with him and Ben Eddy from Canterbury in a taxi after EAU 2019, having had all these emails about the ski trip, he was like, okay, if I'm going to join you, if we're going to throw our lot in with you, you've got to have no antibiotics. So he brought that sort of real clarity that this is how it's a secondary outcome. He accepted that, but this is how we make the secondary outcome still meaningful in it with the way that we're setting up Translate, so that people can interpret the results knowing that whatever we find, it's pushing LATP as stringently as we can. So we pushed it stringently in the primary outcome, only 12 systematic biopsies, not the 24 that a lot of us do. And we're pushing it as hard as we can in the secondary outcome of infection, no antibiotics.
Very good. And I suppose the next thing we should discuss, very important, are the patient-reported outcomes, because And LATP is challenging. You know, you're multitasking. You've got a patient that's awake. You have to worry about their comfort, their pain management. You're trying to cognitively target these MRI lesions.
Get a good local anesthetic in.
Good local anesthetic in. I mean, these are challenging cases to do. How did you find that? And what were your patient-reported outcomes in this trial?
Yeah, so that again was a really important thing that we wanted to look at, to capture the patient experience. And I was conscious at the time of setting this up. So I do a post-biopsy results clinic here at Oxford. Mm-hmm. And so I was regularly speaking with patients who'd had either type of biopsy for whatever reason. We were doing LATP within our active surveillance cohort if they were having a confirmatory biopsy. So I was actually speaking to quite a lot of men around the time who'd had both types of biopsy. And I was hearing very, very mixed reports from patients as to how they found them. And what we actually found in the trial is that in the immediate post-biopsy setting, patients were reporting that the LATP was more embarrassing. It was less tolerable. It was more uncomfortable. So in the immediate aftermath, if you like, of the biopsy, while the patient's, waiting to go home, the findings were against LATP, actually. They prefer the TRUS biopsy. The other thing that we'll come on to with the health economics is the LATP did take longer to do. It took about 50% of time longer to do, both the procedure and the time in the room for the biopsy, because we captured both. But the immediate experience of the patient was less favorable for LATP. And I think that's important to at least reflect on. But then within a few weeks and into the few months of follow-up, it was actually then the other way around. The TRUS biopsy patients were perhaps having a less good experience than the LATP. So, there's something there in both arms that is important, I think.
Yeah.
Just amazing. And look, we could dive in much more detail. We'll put the links in the show notes to the paper and other relevant papers like Prevent and Probe and so on. But I suppose just in finishing up, for rounding up comments, like I said in my discussion today, surely this is the end of TRUS biopsy. Okay, and it's not so much the detection rate, it's not so much the infections, it's the fact that you can do it under local anesthetic, you can walk in and out and no antibiotics.
No antibiotics.
If you flipped it the other way around, and if we'd always been doing local anesthetic TP biopsy with no antibiotics and have a high detection rate, and you try and introduce something like TRUS biopsy with 3 days of antibiotics and a lower detection rate, like it's a non-starter.
Never fly, yeah.
So that's my kind of call to arms, or my interpretation of it to those around the world who are doing TRUS biopsy, saying, well, it's because local anesthetic is TP biopsy is under general anesthetic. It's this, it takes so long, etc. I think surely everybody doing that needs to challenge themselves as they look at the Translate trial. What do you think, Alastair?
A little bit nervous. Okay, so.
Not the reaction I expected.
We have a positive trial, and we found it's better for detection of clinically significant disease. We haven't mentioned the numbers, so let's just say it. So 1 infection in LATP by 7 days, 7 in TRUS. That goes up to 2 at 35 days, 9 in TRUS. So they're different, but the small events, the small numbers of events. That's on infection. We won't go through the rest, but all the rest of the data is in the paper. It's a positive trial, but I think it's a bit more nuanced than that, if I might. And I know that you're just being brilliant, Declan, provocative as always to push discussion, and I love it. But we're not in the position where everyone does LATP. It might be the case in some places, London, pretty much, Melbourne, maybe. Actually, we're in a position where a lot of people around the world perform TRUS biopsy and do it very well. And so the question is, do we have enough evidence to say there should be a wholesale shift? Everyone in the world should shift to doing LATP. Not so sure about that. And actually, Richard, can we say the health economic results?
Yeah, I think we should, and I will. And I think we. So we need to edit this bit out. But what I was going to say is, as you saw in my last slide this morning, the health economics, which we haven't yet published, because that's a whole other paper that's coming. If I may say, we find that the health economics is actually not in favor of LATP. So the way the health economics, and we've worked with really skilled and expert health economists here at Oxford who've evaluated all the data, bearing in mind we only had 4 months of follow-up. So I will caveat that. but based on the 4-month follow-up of these patients, the way that they define this is that the probability of LATP being cost-effective versus TRUS is less than 0.1%. So the actual health economics of this don't stack up for LATP. It's actually the other way around.
In the NHS,
in the NHS,
in
the UK.
Why is that? Are you using Precision Point or some sort of disposable device?
No,
or is it longer time.
It's two main things. It's the longer time, but it's also the adverse patient experience that I mentioned. Yeah. So when you factor in the QALYs, both of those things are against LATP. Yeah. So this will be very important for NICE and for other guidelines committees. Yes, as Alastair said, we have a positive trial for our primary outcome, but there are these nuances that speak for either type of these types of biopsy. And when you factor that in, it's perhaps not as clear cut. And there's still more work to do.
Sorry, Richard. And if I may as well, Declan, you alluded to Precision Point. So yes, in our trial, Precision Point and the BK device were the two that we used. It was agnostic to device, and a couple of leap med biopsies as well. So it was agnostic to device. But I think I know what your question will be. So yes, we did remove the £200, £180 cost of Precision Point to see that if we took that out, that single quite large cost, did that bring, if we took out the extra device cost, did that bring the cost in favor of LATP? And I'm afraid in the NHS, in our system, with our 4 months of follow-up, with our quality of life adjustment analysis, it did not.
Wow, so the QALYs are a thing. But then if we said here in Australia, we tend to do them under general anesthetic and so on. So the patient experience is probably better, but then that additional cost will be very high.
Cost.
Yeah. Well, look, it's amazing.
Despite your reservation, I still think it's brilliant.
Yeah. Sorry, Richard.
Well, so hopefully we'll have another paper to hopefully talk to you about at some point with the health economics, hopefully very soon.
Very good. Look, huge congratulations. I know you want to thank your collaborators and funders. You've mentioned the Trial Centre and your patients. Alastair, anything else you want to add into that?
Well, of course, we want to thank our funders. So we haven't mentioned them. So the NIHR, National Institute of Health Research, HTA, Health Technology Assessment. Richard and I got an email from them in August 2020, height of COVID lockdown, or summers that we weren't having holidays. And we got that, and we were just chuffed a bit, weren't we, Richard? And it's then so thanks to our funder who supported us excellently, the trials unit, and then probably not mention them all by name, but the 10 centres who are all named in the paper, and we've tried to be very open with our sort of authorship on the paper. It's their collaboration and just really sort of can-do approach to it that has enabled us to recruit quickly and deliver a trial, which we've delivered according to protocol. So important, isn't it? It is what it is, and I think it's interesting because there'll still need to be lots of discussion.
Yeah, and if I may, I also want to thank all those that advised us how we set this up. This is the first time that we'd done our own RCT. So the people at the trials unit here at Oxford that helped us with the protocol, the database. I also want to thank the patients, particularly those who were recruited, but also the PPI. We had a lot of PPI helping write the protocol, and we did a trial that patients wanted to have performed, and that's great. It's
true. We have this great group called the Oxford Prostate Cancer Support Group, which Richard and I used to often maybe once or twice a year go and speak in the golf club near the Churchill Hospital, and they can't get enough, can they, Richard? They're so interested, and we did surveys at the beginning. So what would be acceptable? Would you be willing to be randomized? That's such an important question, isn't it, Richard? Would you be willing to be randomized if we asked this question in this study? And then they keep asking us back, come tell us, how's the trial going? And obviously now they want to know, how's it gone? So they're a wonderful, it almost to the point where you think, how could we have done the trial without that kind of input? I think we could say that, can we, Richard? And Steve Tuck, who's the chairman or was the chairman of that group, is actually a co-investigator on our trial.
Amazing. What a great team you have.
And we know a lot of them listen to the podcast, a lot of UK support groups. So shout out to them in Oxford, Steve Tuck and co. Just amazing. Huge congratulations.
Yeah. Time for celebration.
We're chuffed for you. And a lot of the collaborators were in the audience today in Madrid as well. And I'm sure many of you will go out tonight and deservedly have a drink. We might go and join them for a drink.
I think we will.
Yeah.
Congrats, guys.
Great.
Thank you for having us. Thank you.
You're most welcome. That's all we have time from this kind of breaking news podcast. The links from the paper to the Lancet Oncology paper. Wow, what a moment. So
Translate.
proud. Yeah, it's great. Translate this into practice. That's what I'm saying.
That's right,
we
exactly.
should be doing transperineal biopsies under local anesthetic or whatever, and abandoned transrectal biopsy. That's still my clarion call for today. Thanks very much again. We'll be back very soon.